Alright, so now we're going to be moving into the respiratory system. We've seen cardiovascular, we're able to get gases out, move those around, get nutrients out. So how do we actually get the gas in from the environment into the body and also get the waste product, the CO2, out of the body and into the environment? And so that's what's one of the main functions of the respiratory system. We'll first go over the structure of it. We'll look at how we breathe in and out in this first part, and then we'll get into gas exchange and the carrying of oxygen through the body in the part 2 of this lecture. So main functions, what everybody knows lungs for is bringing in that O2. This is how we bring the air in. We get that O2 so we can use for cellular respiration. And what happens in cellular respiration? We make CO2 during this process, and we need to get rid of it. And so the lungs are the way out from the blood, the CO2 from the blood out to the environment. So that's the main function most people know. Also protection of pathogens and irritating substances. We got many pathogens in the air we breathe in. One of the main functions is to protect us from those. But one of the biggies most people don't realize is this is one of the ways in which we can regulate pH. pH is one of those factors, those homeostatic factors we got to keep in range. Otherwise, we're going to have problems very quickly if it gets too far, too high or too low. Okay, so the respiratory system along with the urinary systems are going to help regulate this pH. Okay, and it's going to be regulating it. We'll look at regulation through CO2 is going to control our pH, and we can control our CO2 by regulating our breathing. Right, and then vocalization is another one of those factors. This is how we vocalize, moving air up through those vocal cords gives us our vocalization. Okay, so a lot of what we'll focus on, we'll get into the gas exchange, and we'll focus a little bit on this, and we're going to touch bases with this pH factor both in urinary and in respiratory. So let's look over this bigger process called respiration first, and then we'll see where the respiratory system fits into this. First, we got ventilation. This is considered external respiration. And then we get gas exchange. Two areas of gas exchange are taking place. We have the lungs into the blood. Okay, so we get the ventilation, we bring the air in, then we're going to get exchange of the gases between the lungs and the blood. And then the blood is pumped around, and we get exchange of gases between the blood and the cells. And then what is that finally used for? For the cellular respiration. So that's the overall process of respiration, because what do we need this O2 for? We need that O2 for cellular respiration. That is where it gets used. And where does CO2 come from? Cellular respiration. And so you can see how all this fits in. Where we're going to be focusing most on is we'll be focusing here on ventilation. And for the first part, okay, the external, and then we'll get into the gas exchange. All right, and we'll get external. External is considered lungs to the blood, external respiration, and internal respiration, where we have exchange between the blood and the cells. All right, so we'll get into these two in part 2 of this respiratory lecture. Okay, so that's where we're heading. So our respiratory system, it consists of these structures involved in what first do we need to do? We need to get the air in, right, using our lungs. And what else must have to take place? Once we get the air down into the lungs, we have to get the gas exchange, because where do we need to bring those respiratory, the O2 in? We need to bring it into the bloodstream. Okay, so we're going to have this interaction between the lungs and the blood, because we have to get the gas exchange. We got to get the O2 into the blood and the CO2 out of the blood and into the lungs. Okay, so we have these structures. They're going to be involved in ventilation, okay, bringing the air in, and then gas exchange. Okay, so we have conducting system, and basically that is the main part involved in the ventilation because we're conducting the air down into the lungs. Okay, we're bringing the air from outside in the external environment and bringing the air into the lungs. Right, and then at the very end, the very last part of the respiratory system, or the canals that get there, are the respiratory bronchioles and the alveoli. These are the structures in which we will get exchange. This is where the exchange surface. Okay, we're going to have diffusion. Okay, remember your property is diffusion. We're going to have this very thin layer when we get to the alveoli, because if we want to do lots of diffusion, we need to have this thin layer. Also, we're going to have lots of surface area. So the arrangement is we get into many alveoli, and so we have this increased surface area because what are we doing? We're exchanging gases, and to do that we have to do diffusion. So our little anatomy lesson, we have our upper respiratory tract. First, we bring our air in through either the nasal cavity or the mouth. Okay, down the pharynx, larynx. All right, and then we bring it into those lower levels. Okay, everything above the larynx is the upper respiratory, below it is the lower respiratory tract. Okay, so we move into the trachea. And then as we go down, all we're going to do is continually divide. We're going to be dividing into smaller and smaller bronchias until we finally reach those the terminal bronchioles, where we get to the respiratory bronchioles, and then we get into all those sacs of the alveoli. Okay, and those branches are all housed in the lungs there. Okay. So let's take a closer look at the structures of this conducting system as we move down the lower respiratory tract here. Okay, mouth and nose, pharynx, larynx. All right, that gets us down into the lower respiratory tract, and we move into the trachea. What happens with the trachea? It bifurcates into the primary bronchias, or bronchi, since two, plural, and then the primary break into the secondary break into these smaller, and there's these semi-rigid tubes supported by the cartilage. Okay, so we don't get collapsing of these. Right? When we get down to the bronchioles, these are small collapsible passages with walls of smooth muscle. Okay, kind of like our arterioles, where we got the circular shape around it. So contracting the smooth muscle, we can get dilation or constriction of the bronchioles. Okay, similar to what we've seen in the arterioles in the cardiovascular system. Okay, and that can shunt the air, or the movement of the air, across different regions of the lungs. Okay, so we've come down, we've broken up to smaller into smaller, and then we're coming in. I'll get my big head out of the way here, and we get down into the bronchioles. We're almost getting to the end here. Okay, but this is where we can control the air into the different regions. And then we move into, finally, the respiratory bronchioles that will move us into the final portion, the end part of the alveoli. And this is where we're going to get the gas exchange. So all of this is conducting portion of the lung until we get here, where we'll actually get the gas exchange. Okay, so besides moving the air down into the alveoli, all right, we connect the external environment with the exchange surface, but as that air moves down, what happens to it is moisture is added to it. It is humidified. Okay, we're adding water vapor. When we reach the alveoli, we're 100% humidity. So it is very watery. Okay, we've filtered out foreign materials along the way, try to keep those pathogens out of that exchange area, because if they get into the exchange area, they can get in the blood and then we get infection. Then also, as it moves down, it warms the air to body temperature. So this happens more like if you're up at the mountains in the cold, in the snow, you got to do more of this, and you'll be warming the air because you have to get the air to body temperature, and you have to add moisture to it to get it to 100% humidity. That allows for efficient diffusion of these gases. All right, so now we're in the alveoli. We've come down, we're at the end of the track, and this is where we have all those alveoli. Okay, they're a cluster of balls. We've gone from this one big trachea into all these smaller tubes, and then finally into these little bronchioles, and at the end of the bronchioles we have all these alveoli, these circular structures or sphere-like structures. And what does this do? It gives us this very large surface area. And because what are we trying to do here? We're trying to diffuse gases. So as we move down, we get the ball-like structures, and many of them. So we have many alveoli here. And so we've increased our surface area as we move down the respiratory tract. Because what are we doing? The primary function is to exchange gases. Okay. The walls of the alveoli, they do not contain muscles, they cannot contract, they contain elastin and collagen, so they are elastic. They can expand but recoil. Expand, there is no lungs or no muscle structure to them. Okay, this is key too, because what do we want at the alveoli? We want this very thin layer. We're going to see it's made up mostly of simple squamous epithelial. Simple squamous, remember the thinness of the squamous, and it's simple, so it's only one layer. So that allows us to do diffusion of the gases very rapidly. Okay, we've expanded the surface area, and when we get to the alveoli, we're going to see the cells here. They are very thin, simple squamous epithelial, and that allows us to get that very rapid gas exchange. So now looking at the surface of these alveoli, right? This is one alveoli, here's another alveoli. We're just cut in to these sacs. You can see these tile-like shells or cells. Those are those very thin, simple squamous cells, and those are the type 1 alveolar cells. Very thin. They make up the bulk of the alveolar surface because that is where the gas exchange or diffusion of the gases is going to take place. Okay, you can see the proximity of these cells with the capillaries. These are those capillaries that are wrapping around. They're wrapped around all of this area because we want to have a close association with the alveolar cells and the capillary cells. We want them to be very close to one another so we can get diffusion of the gases very rapidly. These cream-like structures are type 2, and one of the main functions is surfactant. There is a thin layer of fluid across this alveolar surface. All right, and this is going to create surface tension. We'll see this in a bit. And the surfactant is there to decrease that surface tension. And we'll see why that is important in the functioning of the lungs. Besides these, not written here, but these little alveolar macrophages, this is where we get the immune response. We get defense against the pathogens. Okay, but the ones we're going to focus on mainly for our ventilation and gas exchange purposes are going to be our type 1 and type 2 cells here. Okay, and so here's that link. You can see that close association. These alveoli are wrapped extensively with the capillary beds, the pulmonary capillaries, and this is where we're getting gas exchange from the alveoli into the bloodstream. That's the link there. Okay. Fill about 80% of the space between the alveoli, almost a continuous sheet that allows us to get that very quick exchange. And there's very little fluid between these two surfaces because we want, again, distance is going to affect diffusion. If the capillary bed is out here and the diffusion's here and there's fluid, interstitial fluid here, it's going to take a long time. So we have them right in close proximity. There's very little fluid between the surface of the alveoli and the capillary beds. So here is that closeness, the exchange surface of the alveoli. All right, here's the endothelium of the capillary beds. And let me get this off. Here's the alveolar. Those are your type 2 cells. Or sorry, type 1 cells, the very thin. It's looking at these cells here. And you can see there's very little fluid in between. There's not much space that allows rapid diffusion across these membranes. Okay, so very little interstitial place. We'll see some diseases where we get edema. That's going to increase the fluid here, and that would increase the distance and would affect the exchange of gases. So now let's look at where these structures are housed. We have the lungs, we have the primary bronchioles going down into alveoli, and this is all going to be housed in the lungs. And where are these lungs going to sit? They're going to sit in this cavity, the thorax. The thorax is made, we got the borders with our ribs. Okay, ribs wrap around back to the spine, so that forms the walls of it, and also the muscles that attach to it give the structure of the thorax. And then the floor, the bottom of that cavity, is covered by the diaphragm, forms the floor. Okay, we have several muscles in here that are going to be important in drawing air in and expiring air, such as the sternocleidomastoids, the scalenes, you can see here. All right, and then we have the intercostals. We have the internal and external intercostals between the ribs there. And these are going to help move and make this thorax. They're going to change the size, change the volume of the thorax, right? And this is going to be important in our inspiration and expiration of air. Okay, but again, the lungs are housed in this thorax, and we're going to see they're tethered to the walls, tethered to the diaphragm, and tethered to the walls here, the rib cages, right? So if we're able to move the rib cage and move the diaphragm, the lungs elastic and is going to stretch with it. All right, and so we'll see how this operates in a bit, but let's continue on looking at that thorax. Okay, it is a sealed, basically think of it as a sealed container. All right, there's no air getting in from, the only way air is getting in is from coming down the tracheas into those tubes and expanding them. Okay, but the lungs are surrounded by a serous membrane. You can see in the thorax, besides the lungs being in here, we have the heart, right? The heart has that serous membrane, that two-layer membrane called the pericardium, and then we have two pleural sacs, and those are going to wrap around each of the lungs. All right, remember our serous membranes. Our serous membranes have two layers. We have a visceral layer, this layer here, that is basically the surface of the lungs. And then we have the parietal layer, and that's going to be the layer that's tethered to the thorax, to the rib cage, to the diaphragm. That portion, the parietal, the outer layer, is going to be tethered, and in between the two is that serous fluid. And the lungs are going to be stretching in this environment, so what's that serous fluid? It allows to reduce the friction. Okay, with the lung stretching, you don't want friction taking place, so you get all these blisters on your lungs. And so that is the function of that. We'll see it also functions in our inspiration and expiration. So here's just looking at how pleural sacs form, or we think of it as serous. We have that two layers. Right? This would be the visceral layer. If this was the lungs, the balloon was the lungs, this would be the visceral layer, the one surrounding basically the surface of the lungs. And then the outer layer that's tethered to the walls of the lung, and the diaphragm is this parietal layer. And then in between would be fluid. We'd have that serous fluid. Right? And that serous fluid basically holds together those two layers. If you can think of it as if you ever take two pieces of glass, you put some water on the first piece of glass and you stick the other piece of glass on there, you can slide those glasses across each other very easily. But when you try to pull them off, right, it's held together by that fluid. It's hard to pull apart. That's similar as how these lungs are held together, or this pleural membrane is held together, that fluid. And that allows it to give us a slippery surface, all right, allows us to slide, reduces that friction, but it also, because we're tethered, remember this leather's tethered to the wall of the thorax, this layer, the visceral layer, is around the surrounding the lungs, and they're tethered with that fluid inside. When the walls of the thorax change in size, grow bigger or smaller, the parietal membrane's going with it, but also pulling with it the visceral layer. Okay, and so that's how we're going to be able to stretch these lungs, and then when we let go, we're able to recoil back. So now we kind of have to start getting into the physics of the lungs, and remember that the lungs are elastic. They can be stretched. Okay, but what's elastic do? Elastic likes to recoil into smaller. And we'll see our lungs are actually, if they're allowed to recoil with no hindrance, they would be very small. But even when we're not breathing in air and making our lungs bigger, they are already in a stretched state. So there's this force that the lungs want to go smaller. They're pulling in this direction. All right, and the other layer, is pulling in this direction. All right, so one's going this direction, this one's going in this direction, and this creates a force, a pressure in here that is called subatmospheric. So how we're going to be moving moving air in is by changing pressures. Okay, changing pressures in the lung. What we got to realize is that there is pressure out in the gases exert a pressure. The pressure that the gases out in the environment exert a pressure. All right, and that pressure, we can call it atmospheric. All right, and we will see at sea level, we can have 1 atmosphere of pressure. That's the pressure out in the air, or one you might have commonly seen, 760 millimeters of mercury. All right, this is another measure in pressure, just a different unit, but these would be roughly equal to each other. Okay, 760 or 1 atmosphere. What we're showing here is that because the lungs want to recoil, they have this force in this direction, but the walls are pulling it in this direction. We create this interpleural pressure that is subatmospheric. So let's say we're using 760. If it's negative 30 millimeters of mercury, we would have pressure would be 757 millimeters of mercury in there. All right, it's 3 below the atmosphere, subatmospheric. Okay, so we gotta get this thinking involved to get where we're, okay. Again, the elastic lungs are forced to stretch. That's pulling in this direction. The lungs want to recoil, so they're pulling in this direction. And that is these two forces create this subatmospheric pressure. Okay? This is important because this is going to allow us to keep the lungs tethered to the rib cage. Right? So the intrapleural pressure never equilibrates, never becomes equal to the atmospheric pressure, because if that takes place, right, it's always subatmospheric, so there's always enough pressure to keep the lungs pushed against the walls. But if that doesn't take place, we're going to see the lungs are able to recoil. But let's look at this in our intrapulmonary pressure. Okay. In inspiration, intrapulmonary means the pressure in the lungs. Right? What is the pressure in the lungs? Intrapleural is that pressure that is in between those two layers, the parietal and visceral layer of the pleural sac. And you can see when we're inspiring, this is negative minus 30 is subatmospheric. Okay, plus 3 is above atmospheric. It's higher than the atmospheric pressure in the environment. But what you see is this pressure is always below, right, the interpleural pressure, and that allows the lungs to stay tethered to the wall. All right, if the lung pressure is more, the pressure inside the lungs is more, it's going to keep the lungs stretched and keep them pushed against the wall. But what happens if the interpleural pressure for some reason became lower than the interpleural pressure? That would allow them to not be tethered and allow the lungs to just recoil. So we'll see this in a bit on how this is taking place. Okay, but just keep in mind that that pressure between those two layers of the pleural sac, the interpleural pressure, is always lower than what is taking place in the lungs. All right, and this is what we see. This is a closed space. This lung is closed space. But remember the interpleural pressure, the pressure inside the lungs, was a negative 3. So it's below atmosphere. Here's the case in which if the compartment gets open, all right, what's the pressure here? The pressure is atmospheric out here, and that would create an atmospheric pressure in the interpleural space. All right, so this interpleural space would be 760, and say this would be 757. Now where's a higher pressure? The higher pressure is in the interpleural space. The lungs won't stay tethered, and that allows the lungs to recoil. Remember I said the lungs are much smaller. They're always in a stretched state. All right, but if we open up the space and create a greater pressure in the interpleural space, that will cause them to recoil. They won't stay tethered to the wall. And what happens is we get what's called collapsing of the lungs. Okay, patch up the hole, repressurize, lungs can move back into their space. So we got to keep that interpleural pressure below the pressure inside here. Otherwise, we get the collapsing of the lung. So let's look at factors that are going to be involved in work in the breathing. In breathing air in, inspiration, or breathing air out, expiration. And one of the drawing features is that it's going to be pressure gradient. By changing the pressure in the lungs, right? If the pressure is greater in the lungs than in the outside environment, air is going to move out. Air is going to go from an area of higher pressure to an area of lower pressure. All right. If I create an environment that is lower in pressure than the environment, then the air will move in. So that's what we're going to be doing. We're going to be changing pressures, and how we're going to do this is by, we'll see here in a bit, changing the volume of the thoracic cavity. Okay. Lungs have the ability to expand. If I expand, change the volume to bigger, we're going to be able to inspire. And if I make the lungs smaller, that creates smaller volume. It's going to allow for expiration. And we'll see the relation between volume and pressure here in just a second. All right, there are some terms to know. Compliance, and that's the ability to expand. All right, I need to expand my lungs to be able to get inspiration. So if I inhibit the ability to expand, then I'm going to have a problem inspiring air. There's also resistance. Okay, resistance comes from that elasticity, and we're also going to see there is some resistance to distension to this compliance via surface tension. Remember, there is fluid on those alveoli, and we're going to see this creates what's called surface tension, causes a force to try to keep the balls from, or prevent the balls from the alveoli from expanding. Right, and we're going to see how we overcome this. There's a feature that certain cells in the lungs secrete to help release that surface tension. All right, so let's look at some factors that these terms here involved in getting ventilation, inspiration, and expiration. We have compliance, ability of the lungs to stretch. Okay, this is going to lead to inspiration. Elasticity is the ability to recoil, the lungs to recoil, and that's going to lead to expiration. But, all right, the ventilation depends on these abilities to expand. And compliance is the ability of the lungs to stretch. And if I'm able to stretch my lungs, I'm able to lower the pressure, and I'm able to bring air in, inspiration. So high compliance, easily stretch, will allow for easy movement of air in. The low compliance, okay, will require more force to expand the lungs and will inhibit the ability to inspire air. So when there's diseases that affect this ability of this compliance, they're termed restrictive disorders. All right, and they're going to affect the ability to successfully breathe in air, inspire. Okay, some factors that are going to affect this compliance and therefore affect the ability to breathe in properly are, one, if we had a fibrotic lung disease, if we took, remember, these lungs are elastic, and we inserted some elastic scars in there, that's going to affect the ability to stretch them. Another way is production of surfactant, and we'll look at a certain case and when this takes place. But if you remember our little alveoli, there's water on there, and this creates surface tension, which creates a pressure to collapse those alveoli, helps prevent them from stretching. We need them to stretch. So the surfactant is going to loosen that surface tension and allow those alveoli to stretch properly. Okay, so is compliance the whole part of elasticity? No, because we have stretch, but we also have the recoil portion, and that is the elastance. All right, so the reciprocal compliance is elastance, and elastance is going to be involved in springing back and going to allow for expiration of air. So we have to have proper elastance to do the opposite, go in the opposite direction to expire air. So on that previous slide, we talked about one of the factors that's going to affect the ability of lungs to stretch is the lack of surfactant, because there is surface tension on those alveoli. All right, and so your alveoli, they're not all made the same size. They're not all uniform. There are some bigger ones and there are some smaller ones. They all have fluid on them, which creates this surface tension. I don't want to get into all the mathematics here, but what we see here is, I want you to focus on the pressures, the surface tension, right? Greater P there, it means there's greater surface tension and greater force to collapse that ball. The forces, the surface tension causes the force to pull these towards the middle. All right, if I have this greater force pulling to the middle, I have a harder ability to stretch them. All right, this is what the law of Laplace is saying, is that the smaller balls or smaller alveoli are going to have greater surface tension, where the larger are going to have smaller, about half in this case, right? So how do we overcome this is, right, so let me get my face back here, is we need the same change of pressure is not going to let air in this one as here. We can only change our pressure so much, but we want all our alveoli to stretch uniformly. We want the small ones to stretch while the big ones are stretching. In this case, we would have to, if we didn't have any surfactant, okay, we may be able to stretch the big ones, but the small ones are going to stay collapsed until we create a greater, overcome that greater pressure and move them. And so how we overcome that is we put surfactant. You have those alveolar 2 cells too that secrete surfactant into the alveoli. Little blue dots are going to reduce the surface tension. The surface tension is created by the attraction of those water molecules that are on the alveolar surface. They attract each other, and that causes this drawing force. If we reduce that attraction of them, we reduce the surface tension, and you can see if we put surfactant in, there's a higher amount of surfactant in the smaller, lesser in here, and that will allow us to create the same pressure in each of these. All right, and allow us to be able to expand. While the big ones are expanding now with surfactant, the smaller ones will be expanding the same rate when we change the pressure in the lungs. All right, so that is the role of the surfactant. It's reduce that surface tension so all the alveoli, we can stretch them. All right, there is a case where surfactant isn't produced. All right, when you are in mom's belly and you're being formed, surfactant doesn't start being secreted by the lungs until later on in pregnancy. You know, later, pretty closer, a lot closer to delivery time. And so what babies are not make it all the way to the normal delivery? Premature babies. Premature babies are born, say, before the time that surfactants. If they're very preemie, they may not have. Okay, there's the surfactant, the alveolar 2s. Right, and this is what I was heading towards. The newborns, premature babies will end up with respiratory distress syndrome, right? And that's due to the lack of surfactant. If they're born before the time frame that surfactant's starting to be produced in the baby's lungs, all right, they'll have an inadequate surfactant, and they're going to have these lungs that have low compliance. They're not going to be able to stretch. They're going to have to work heavily to try to stretch these. And that's going to put distress on a baby, and also will affect the ability to successfully get enough gases in and get gas exchange. So how do we overcome this? One of those is to incorporate artificial surfactant. Okay, put surfactant in. So here's what a normal alveoli look like. You can see nice and stretched, whereas without surfactant, it is harder to stretch them. There's lower compliance, and you can see we're not getting as much air into these, and that's going to affect the diffusion of the gases and will affect the ability to the baby to successfully get enough oxygen to all the tissue. All right, so that is one factor in which surfactant goes by the wayside there. All right, so let's get into the mechanics of ventilation. Ventilation is bringing the air in, inspiration, and breathing the air out, expiration. And so how are we going to do this? What are the mechanics that allow us to draw air in and to draw air out? Okay, we're exchanging the air between the atmosphere, the outside environment, and bringing the air into the alveoli so we can get gas exchange. We got to successfully bring enough air in so we got enough surface area to get a successful gas exchange. So this is the first part of this respiration. Breathing in, getting the bulk flow of the air in via ventilation. So a respiratory cycle, again, inspire in, expire out. We want to inspire the air in, bring that oxygen in so we can get exchange of oxygen. Then we want to get exchange of CO2, and we want to expire that out. So what are the mechanics? What is going to be the drawing feature to allow ventilation to take place? Again, pressure. There is pressure. The gases in the outside environment exert that pressure. Okay, 1 atmosphere or 760 millimeters of mercury at sea level. That's the pressure that the gas is exerting in the outside environment. Okay, so to be able to successfully get gases in or out, we have to change. We have to make the pressure inside our lungs. We either have to make it below atmospheric or above atmospheric. Okay, below atmospheric allows us to bring in air. Air is going to go from high pressure out here into the low pressure that's in the lungs. Okay, if we increase the pressure in our lungs above atmosphere, now we're going to go from the high pressure of the lungs out into the environment by expiration. Okay, we're going to do this again by changing pressure, and we're going to see how do we change the pressure in our lungs. All right, we do this via muscle contraction, and we're going to be able to change the volume of the lungs. All right, we're going to be changing the volumes using several muscles. Okay, for quiet breathing, when we're just sitting restfully, for inspiration, it's going to be the diaphragm and some of the external intercostals. And then when we need to do deep inspiration, well, scalenes, and not here is the sternocleidomastoids, those muscles up here in the neck tethered to the thoracic region. Okay, we'll see these muscles are involved in inspiration. So what do you think they're going to do pressure-wise? Okay, pressure-wise, they're going to decrease the volume. If they're allowing us to inspire, they're going to decrease the pressure. And how does this pressure or volume change relate to pressure? All right, we got Boyle's law. You can see we got a volume. Remember our lungs, they are in a closed thorax. Okay, so I can expand them. If I expand that region, what happens to the pressure? Now if I make those same lungs smaller in volume, you can see the pressure increases. This is called Boyle's law, right? The lungs are the same. They are the lungs. I can change the volume of them, but if I change the volume, then I change the pressure. They're interrelated, right? Inversely related. As volume goes up, pressure goes down. As volume goes down, pressure goes up. Okay, and that is how we're going to change the volume and in turn change the pressure and allow for inspiration or expiration. All right, so let's look at first this movement of the diaphragm. How do we get, here is our diaphragm. When it contracts, it pulls the lungs. Remember, the lungs are tethered here, and as the diaphragm moves, so do the lungs. The lungs were originally here, and as the diaphragm contracts, pulls the lungs down, and now we have this added volume to the lungs. Remember, as volume goes up, what happens to pressure? Pressure goes down. Lower pressure in the lungs, lower than the environment, air can move in. That gives us our inspiration. Okay, what happens when our diaphragm relaxes? Remember, our lungs are elastic. They're pulling. They want to recoil. All right, this here stretches the lungs even further. Now when the diaphragm relaxes, the lungs recoil back, and now I went from here into a smaller volume. All right, as volume goes down in volume, what happens to pressure? Increase in P. So when the diaphragm relaxes, the volume goes down, pressure goes up, and what happens to the air? We expire it. All right, that's what we're going to be doing. That's simply all we're doing to bring this air in or out of the lungs for the ventilation. Now let's look over a respiratory cycle. That's an inspiration and an expiration on what's changing pressure-wise as air is moving either in or out. First we'll look at the inspiration. All right, and we'll look, basically I want you to look at these two, this here and here. We won't focus too much on the inner pleural pressure, but alveolar pressure, this is the pressure in the lungs, or interpulmonary pressure as you've seen in the other slides. Right. Here is the zero. Zero is atmosphere. Okay, what is the atmosphere? 760 millimeters of mercury, or 1 atmosphere. All right, going below is subatmospheric and supraatmospheric, above atmospheric. So let's look what happens when the diaphragm contracts. What happens to our pressure? our alveolar pressure decreases. And what happens when our alveolar pressure decreases? Where does air go? We're below atmosphere. So now air from the environment, the pressure out here in the environment is lower than in our lungs, or sorry, higher than our lungs. Our lungs are lower than the atmospheric pressure, and air is going to move in. And you can see that taking place here. And air is going to continue to move in until what? Till the pressures are equal again. All right? The pressure in the lungs is now equal to the pressure out here. And what happens to the movement of air? It ceases. All right, so that's what's taking place with inspiration. Diaphragm contracts down here. That pulls the lungs, stretches them out, creates that greater volume, and creates lower pressure. So this inspiration, how do we make these volume changes? How do we decrease the pressure? By making those volume changes. And what muscles are, it's going to be muscly driven. First, the diaphragm is going to be the greatest component. Okay, when the diaphragm contracts, right, moves down, pulls the lungs, creates that volume change. Several other muscles, external intercostals, another muscle. During quiet breathing, typically most of it's diaphragm, a little bit of external intercostals, and then when we start doing more deeper breathing, group some of the scalenes and also the sternocleidomastoids. So these muscles, the external intercostals, the scalenes, the sternocleidomastoids, bring the lungs up and out. So that further increases the volume. So when I need to do a deep breath, I start recruiting more scalenes and sternocleidomastoids, and that helps bring my thoracic cage up even further and out even more, and creates a greater volume change. With greater volume change comes greater decrease in pressure, and more air can move in. So that's what's taking place with inspiration. But quiet breathing, diaphragm, external costals, some of the scalenes. As we go into deeper breathing, recruit more of the scalenes and also recruit sternocleidomastoids. Those are the muscles up here, tethered to the rib cage, help bring the rib cage up and out. So now let's look at the kind of the reverse of inspiration in expiration. Now we're wanting to get the air out of the lungs into the environment. And so what we do for inspiration is we increase the volume, decrease the pressure. Now we're going to decrease the volume and increase the pressure to perform expiration, right? To move that air out. So what do we have going on here? Alveolar pressure increases. How do we do that? We're going to decrease the volume. And how we decrease the volume. Remember, our lungs are elastic, so they want to recoil. So what's the main draw for increasing the volume is that diaphragm contracts and pulls the lungs. When the diaphragm relaxes, that allows the lungs to recoil, to bounce back, because they are elastic. So for passive expiration, when you're just breathing quietly, or quiet breathing, when you're just, right, you're not forcing out the breath, it is that passive elastic recoil of the lungs that causes expiration, because that is going to cause the decrease in volume and therefore the increase in pressure, and now air will move out. When we want to exhale forcefully, we recruit other muscles. We recruit the internal intercostals and then abdominals, and what that's going to do is going to draw my rib cage down and in. So if I draw it down and in, it's going to further decrease the volume in my thoracic cage, and therefore further decrease that volume, and therefore further increase the pressure, and therefore I'm able to breathe out or expire more air. Right? So passively, for quiet breathing, recruit the internal intercostals and abdominal muscles when we're doing full breath out. Right? So let's look at this over our changes. Here's our pressure again. Alveolar pressure. What's the pressure in our lungs? Right? And now we're expiring. We did inspiration. Right? That's, again, the 0 point is atmospheric pressure. So anything below is subatmospheric. Superatmospheric is above. So pressure increases here when we're going for expiration. And so let me get my big head out of the way, but all right, we're going to see what happens as I increase the pressure. I decrease the volume. Air or pressure increases in the alveolar, and you can see as pressure decreases, what happens to the volume of air in the lungs? It decreases. I'm expiring now, moving that air out of the lungs. And this will continue until what? Until the pressure in the lungs equal that of the atmospheric pressure. When those equal, air stops moving because pressures are equal, and now we're back into inspiration. Okay, so that is the change. For inspiration, we're increasing the volume, okay, decreasing the pressure. Pressure is higher out here than in the lungs, and therefore air moves in. For expiration, I'm decreasing the volume, therefore increasing the pressure. The pressure is higher in my lungs than it is in the outside air, and therefore air moves out, moves across that, if you want to put it, pressure gradient. All right. So that is how we move air. Now let's on how we measure air. Okay, we may want to do this in the medical setting. We would use a spirometer. If we were in class, we would use a spirometer. We wouldn't be using the wells here, the water well, but we would use a system in which it measures the volume. We blow through the tube, and we can get a measure of the volume, how much air is being either inspired or expired. All right, that's the job of the spirometer, and this is key in medical because ventilation can determine how much gas exchange. If we're not able to move too much air in, we're not going to be able to get sufficient gas exchange, get enough air in there, get sufficient gas exchange, and therefore that will affect oxygen levels in the blood, or carbon dioxide levels also. So with our spirometer, we can measure lung volumes. Volumes are the air we move in and out. Right? We can look at inspiration and expiration of how much air is being moved. We can add certain volumes together to get capacities. But let's first look at the certain volumes we can measure. There are 4 volumes here in the key. You can see that we measure using a spirometer. Okay, normal breathing. No other breathing, just sitting there breathing in and out. Here is what we would measure as your tidal volume. All right, or your quiet breathing. You can see here. All right, this is just sitting there. Normally when you're sitting still, resting, that is roughly around 500 milliliters, right? A small bottle of water. All right, so that is tidal volume. Now, if I was to breathe in normally, and then breathe in as much as I can, that would give me this volume. My IRV, or what's called my inspiratory reserve volume. Right? Measure roughly 3,000 mLs or 3 liters. All right, and this will differ between age. It also differ between male and female. See, males usually tending to be larger than female. And then, what if I'm breathing normally? And at the end of my normal exhale, I exhale forcefully. That would get me this volume here, my ERV, or my expiratory reserve volume. All right. And then when I've completely my lungs are not completely devoid of air. There is still a residual volume, and that's around 1,200 milliliters. And sorry, I forgot ERV, roughly around 1,100 milliliters. So those are the 4 volumes we can measure using the spirometer. We can add some of these together to get certain capacities. So you can see here my vital capacity. Right? This will be one common measurement. Vital capacity is my IRV plus my tidal volume plus what else? We got our, right, there's tidal volume, the IRV, so IRV plus tidal volume plus ERV, inspiratory reserve. All right, that will give me my vital capacity. See, there's a total lung capacity. What might that be? That would be everything we measure or added with the vital capacity, but then now we're also including the residual volume. This is the total capacity of the lungs, and roughly around 6,000 mLs, depending on what you're measuring. All right, so that is capacity, or volumes and capacities. So here's those definitions in writing: the ERV, residual, tidal volume, right? IRV. Okay, and again, these differ with age, with sex, also height and weight. So typically, adults are going to have larger than kids, of course. Sex, men are going to have typically larger volumes than female when it comes to lung volumes. Height, taller is going to be more, and weight the same. All right, would be more. So that is kind of, you got to juggle that. So when you were measuring these in the medical field, we have values for different ages and different sexes, so we can measure those values against what's considered norm. And we already discussed sums. We can sum those volumes to get capacities. The measure would be vital capacity would be one. Total lung capacity, another one we use. We're going to use vital capacity here in just a second. Okay, because there is a value called forced vital capacity. Okay, what measuring I would be measuring? I'd be measuring I'd be forcing out. I would take one full inhalation and forcefully exhale the exhalation. All right, so forcing it out as fast as I can. All right, that would be your forced vital capacity. In that forced vital capacity, we can get a measurement called FEV1. All right, what is the volume of air exhaled in 1 second during that forced exhalation? So over 1 second time, how much of that air am I forcefully able to push out? And this is good because it can give us a measure of certain disorders. Some of those obstruction disorders, bronchoconstriction, dilation, these are all would affect this ratio. Right? We would take the ratio FE1, how much was I able to force out? Right? Over how much what is my vital capacity? How much do I naturally force out given as much time? So when I that's FEC. How much can I forcefully out? And on the numerator, I'd have how much of that I actually did in just 1 second time. Right? And you can see normal values 70 to 80%. Should be 70 to 80% of the forced vital capacity I should be able to blow out in 1 second. All right. If I'm not able to do this, if it's lower, meaning I'm not able to expel as much air out in 1 second, that would be a common sign for what we call an obstructive disorder. Obstruction is going to affect the ability to exhale the air. All right. And then there is also restrictive. We've already discussed this a little bit. Restrictive is compliance. All right, compliance is reduced, so what do you think is going to happen to my FVC, my forced vital capacity? I'm not going to be able to bring in as much air, so that's going to be much smaller. Obstructive will have diminished because of airway resistance, and this is going to greatly affect the ability to exhale. So common obstructive disorders, COPD, asthma also narrows, right? We get constriction of the bronchial, so that will also affect the ability to exhale. Right? Whereas restrictive, ability to expand the lungs, we're able to move them back in, but the expansion, we're not able to expand the lungs, therefore not able to breathe in as deeply as we once were able to do. And this is greatly going to affect ability to transfer oxygen and carbon dioxide. Right, so looking at these, you can see a normal lung. Right, here's the volume exhaled. Here is the FEV1. Right, and you can see this is roughly between 70 and 80% of what the total volume, the FEC, would be. You can see with restrictive, both restrictive and obstructive disorders, we're going to have decreased ability to breathe in air, so we're going to have smaller FECs. Plus, what we see is the FEV1 is greatly affected by obstructive disorders, ability to exhale. All right, our restrictive, we may get closer to 1, or it may be somewhere in the normal range, but what did we see with restrictive? We see if our FEV1 was somewhat in the normal range, or my FEV1 over FEC is in that normal range, 70 to 80%, but my FEC is greatly diminished. That might be a cue for a restrictive disorder. Whereas if I have an obstructive disorder, my FEV1 over FEC would be lower than that 0.80 or 0.70. Sorry, 0.70. All right, and my FEC would also be lower. So that would be a cue for obstructive disorder. So reduced FEV1 over FEC is a definite trademark for obstructive disease. All right, so it's important that we're able to measure these so we can get these values, so we can kind of help pinpoint what's going on in the lungs and where the issue arises. Is it in the compliance, or is it in the airways? Where is the issue? And these measures, this FE1 over FEC and FEC measures, allow doctors to do that. All right, so this is the end of ventilation. We're able to get the air in. Now, on the second part, we're going to get into gas exchange. How do we exchange the gas? And then how is that gas, once we get it into the blood, how is it moved around the body? All right, so that will take place in the second lecture, and we'll see you in a bit.